Well, it's 7 o'clock. Good evening, everyone, and thank you very much for joining us tonight for the last of this webinar series for supervisors and registrars and primary care clinicians. I would like to start this evening by acknowledging the traditional owners of all the lands on which we meet across the state today, and pay our respects to their elders past, present and emerging. So tonight we're going to have a look at some of the slightly sort of vexed questions that have come up in recent times about antenatal screening with the expanded panels that are now available. Before going into the details of that, could I go to the next slide, please? So we welcome you to ask questions as we go through. The questions are, if you could please be kind enough to use the Q&A button at the bottom of your screen there, rather than the chat. Leave the chat for if you're having technical problems, please, but use the Q&A and we will talk to them during the course of the webinar. The other thing to let you know is just a reminder that there will be a QR code at the end. So if you want to use any device to take a photo, to scan the QR code or get it from chat, and then you'll be able to download a certificate of participation in tonight. Thank you very much. Next slide, please. So delighted to welcome Clare Walker, who many of you know. She's one of our GP obs out of Longreach and president of RDAQ, many other things besides, but that's all I had room on the slide for. And we've got Melody Menezes and Alice Poulton joining us from the Monash group down south. And we've allowed them by Zoom because we feel that the COVID risk is low with Zoom. And also, of course, my colleague Rebecca Locke from GPTQ, and she will be co-hosting with me this evening. So without further ado, if we could go to the next slide. And Claire, if you'd like to unmute yourself and introduce us to Rachel, please.
Hi everyone, thanks for having me tonight. So I've just put together a patient that represents something that we see every day in our practice in the far reaches of the state. So Rachel is a 32-year-old female who attends your practice in far western Queensland. She's with her husband and she is planning a pregnancy. She has no significant risk factors for any genetic abnormalities. But she is asking if there's any tests that she should be done prior to getting pregnant. And you start rattling through all the investigations that you know she should have a varicella and a rubella serology checked, as well as a few other things. And then you recall that your RANZCOG statement stated that all couples should be offered carrier screening for common genetic conditions. And that's something that has been changed in the last few years. And so you go and look things up so that you can get things right when you think about how we are going to proceed with this case.
Thanks, Claire. So what we might do now is hand over to, I think Melody comes next, or Alice, I forget, but we'll go to, but really we see this a lot, don't we, Claire? And it would be fair to say that I think general practice or general practitioners, we've got ourselves quite confused about what we should and shouldn't be offering, and you know, to what extent we should be taking this on. Would that be your view as well?
I definitely agree, and things, it's a rapidly changing area, and for those of us who've been in general practice for a while, you just get into the swing of a certain guideline and then it changes, and then you have to get your head around a new one. And this one in particular is challenging because you're testing for things that a lot of us don't have a lot of intimate knowledge, and then we're often fearful that we're going to find something that we don't know the answers to. So it's an interesting conundrum.
Thank you. Next slide, please.
So I might jump in. Yeah.
Yeah, go for it.
You're happy to. So hello everyone, and thank you for having me as well. As Claire said before, you've suddenly remembered that RANZCOG statement has stated that all couples should be offered carrier screening. And so I thought it'd be helpful to sort of run through what those recommendations actually are. So information on carrier screening should be offered to all women planning a pregnancy or in the first trimester of pregnancy. And options of carrier screening with a panel for a limited selection of the most frequent conditions in the Caucasian population, or screening with an expanded panel that contains up to hundreds of disorders.
And I think, Alice, that up to hundreds is where we as GPs start having a bit of an issue, because there are, oh, sorry, Melody, I might hand over to you. We are, as GPs, very comfortable and familiar with things like, well, not comfortable, but we understand cystic fibrosis and SMA and so on, much more. But when we look at that hundreds of panel, that really starts terrifying us, I think. We just could not have that level of expertise here.
Yeah, so I think probably these expanded panels with Mackenzie's Mission, which is a government-funded research study offering this screening to a certain number of couples, that's going to be the way of the future, but it's very rare that we'll actually get a couple that are high risk for the same things. So Alice will show you our data, but we have found that over 70% of people carry at least one thing. We know that to be true, but it's only an issue either if it's X-linked or if the couple carries the same genetic syndrome. And I think if you're ordering a panel through a provider, they should be offering genetic counselling and having a pathway for your patient so that you don't have to delve into this and you know where to refer to. And I'll pass it back over to Alice to keep going with that, if that's all right.
Yeah, perfect. Thank you for that. Can we move on to the next slide, please? And we can go into a little bit more detail about
just before we do move on to the next slide, there's been a really interesting question, and it's one that popped into my head as you were speaking before. So are there similar guidelines for frequent conditions in non-Caucasian groups, or are we limited at the moment to that Caucasian group screening?
My understanding is for the more limited screening, typically it does normally apply for, well, the more population-based screening is on a more Caucasian sort of looking from a population of Caucasians. There is more specific sort of ethnic carrier screening that I know that is offered in some schools around Australia, more specifically people with Ashkenazi Jewish heritage. Mel, you might be able to add something to this as well.
Yeah. So CF, SMA and Fragile X, which the RANZCOG guidelines mention, are the most common genetic conditions in Australia, but they're common in the Caucasian population, although all ethnicities we're finding do carry these things, so it is relevant for everyone. That expanded panel is what they call the pan-ethnic panel. So because it looks for more things, we're more likely to, I guess, it's a broader panel or a broader screen. So there aren't specific screens for different ethnicities, because we know that people that may not be Caucasian can still carry the things that are common in the Caucasian population. So those three conditions are still relevant, but that expanded panel will touch on more things like some of the hemoglobinopathies and things like that, the thalassemias, but as well more rare syndromes that can be present across the population.
And do you know, is there increased cost for the pan-ethnic or the broader screen?
Yeah, there is, and that will vary by state in terms of what providers are offering. We offer an expanded panel through Invitae, which is a company in the US, and you can actually sign up for that on your own if you feel comfortable ordering this. And it's $250 US for the first person to be screened and $100 US for the partner, and they screen for about 300 conditions. So that is a very cost-effective panel, but in terms of the local panels, they range from about $385 or $400 to about $1,200. So the cost really varies, yeah, based on the provider. We offer at Monash Ultrasound in Melbourne this $350 couples screen, US dollars. But I think there is also Eugene, which are like an online web-based platform that are offering an expanded panel for a similar price point. So that's something else that you can look into. And Alice covers a little bit of this in her slides as well.
Thanks.
Yeah, and I think it'll be worth circling back to the cost issue in a bit, won't it? Because obviously, not only ordinarily do a lot of our patients not have that kind of funding available to them, but particularly now post or during COVID, where people maybe have lost their jobs or be on, on job seeker or so on, it becomes increasingly out of the reach for many people, doesn't it? Anyway, Alice, we better get past the second slide, haven't we?
I'll just quickly say, though, that the Mackenzie's Mission, which is the government-funded program, is looking at offering this and looking at offering it to the Australian population in a way that we are hoping is going to be bulk billed or something. So we are recruiting for that study in Melbourne, and patients are being offered that panel, which is about 1,000 conditions, I understand, and it's a couple screen. And at the moment, that's free if you're part of the research study, but we're hoping that that's going to be across the board. And I know that they've just started recruiting, so it will be rolled out to the other states as well as they go along.
Thank you.
If we could please move to the next slide. And so I think we'll circle back to the basics before we get into a bit more depth in the types of screening platforms that we can offer, and really just cover what is reproductive carrier screening and why is it important. So reproductive carrier screening tests healthy adults to see if they have an increased chance of having a child with an autosomal recessive or X-linked genetic condition before conception or prior to birth. So there are hundreds of inherited genetic conditions that are present in infancy or early childhood, and most of these are rare. But how come, although these conditions might be rare, individually grouping them together, they're not insignificant, and they end up affecting about 1 in 400 people. Additionally, most children born with these conditions are born into families that have no prior family history. Next slide, sorry.
Just before you go to the next slide, Alice, I was just going to say, when I was looking through those slides last week, I was really struck by that last comment, which is why I bolded it actually when we went through the slides, because I think that probably does help us as primary care physicians to help counsel families, isn't it? Because I think there probably is that view that, well, it's never happened in our family, so it perhaps it's not on people's radar. Would that be your understanding, Claire, about things, about this? Yeah.
Yeah, absolutely. And I think there is this feeling like, oh, I'm young and I have no family history, so I don't really need any screening. And that's just for either older people or people that have this risk. And I think understanding that there is a risk, and even just with the simple tests, I think there's this feeling that they rule everything out, whereas you know, obviously, not, you know, we'll talk about soon, but you know, the NIPT or Nagles are only really looking for, you know, the 3 different conditions. So so it's important to understand and to counsel the patients, because there is a lot of misconception out there.
And look, Cate, I'm so sorry. I was going to introduce you later, but I think that's going to be an error, because there you are sitting on our screen. Would you like to just introduce yourself? And if you've got anything to comment at this point, please go ahead.
Yeah, hi, Cate Nagle. I'm the Professor of Nursing and Midwifery at James Cook University and the Counsellor Hospital and Health Service. And my background in this area goes back to working at Monash Medical Centre in the Fetal Diagnostic Unit. And then I'm going to talk later about a decision aid, but I think that's all from me at the moment.
Thank you. Right, Alice, back to you.
But I do think, as you raised before, it is interesting, and I think that's probably why the guidelines have changed to be what they are, given that we're seeing most people who are presenting with a child with one of these conditions don't have a family history. Please move to the next slide. So what are the main things we need to ask ourselves when we're beginning to have these conversations about reproductive carrier screening with our patients? The first question is, do we want to screen the individual or do we want to screen them as a couple? So individual screening is where one member of the couple is offered testing first, and usually this is the female member of the couple. The reason for that is due to X-linked conditions. So generally men aren't tested for these X-linked conditions, as the purpose of this testing is to understand the chance of having an affected child, and we therefore don't want to learn about an affected parent incidentally. The advantage of using this sort of type of testing, so testing one member of the couple first and only testing the partner if a positive result is returned, is that it can reduce the overall cost of testing for some couples. Couple screening refers to testing both members of the couple simultaneously. So the couple may be then given their individual results. However, some platforms just give the interpretation as a whole as a couple. So they get given a high risk result or a low risk result that is only relevant to them and their current partner. But yeah, as I said, some other platforms give individual results as well as an interpretation of their chance of having a child with one of the conditions screened for. The benefit of doing it this way is the result of the couple is available within the same time period. So it's particularly relevant if someone's presenting during pregnancy, just to get that result, not having any further obstacles. Additionally, it can reduce anxiety from waiting for the partner's result when the first person has been found to be a carrier of one or more conditions.
Alice, could you or Melody give us some examples of where you may recommend couples counselling versus, couples testing rather than an individual, please?
Yeah, so like I just highlighted then, it can be really relevant if someone's presenting during pregnancy. So if they're early in pregnancy, we normally lean towards testing both members of the couple at the same time, just so we can get that result back to them in a timely manner. It's normally more relevant in the context of expanded carrier screening, which I'll go into a little bit more detail about shortly. Given, as Mel said before, about 70% of people do come back as a carrier for something, it just ends up being so likely that you'll need to end up testing the other member of the couple that it often saves a fair bit of time to do it at the same time. Whereas when you're doing that more limited screening, only looking at 3 conditions, it's less likely to come back as a carrier for one of those conditions. And in that case, sometimes the woman will be the only person who's tested.
So for the expanded panel that we offer, if women are pregnant, we will only do it as a couple screen because of that turnaround time. It is a bit longer. So they can have the limited panel if they choose to do that, but if they want to have the expanded, because of that turnaround time and because it's the cost for the panel we use isn't too onerous, it's $100 US to screen the partner, and there's more than 75% chance we'll have to screen the partner anyway.
Perfect, thank you, Mel. And so the next question that we need to decide is it better to do it pre-conception or prenatally? So while it's recommended couples proceed with testing prior to conception to maximise reproductive choices, we acknowledge that most individuals don't present until they are pregnant. And it's still worthwhile offering this testing, and as the guidelines state, women who present in early pregnancy should be offered this testing. As we've just sort of flagged in that question, if couples choose to proceed with an expanded panel early in pregnancy, we do recommend that both members of the couple are screened at the same time, just to minimise any further delays in obtaining a more meaningful result, particularly as we anticipate that most individuals will be a carrier of at least one thing.
Thanks, Alison. I mean, that is a real learning point for me. My practice will change as of tomorrow because that is not how I have been approaching this. Claire, a comment from you on this? You're obviously more up to the minute than I am with this.
It is really challenging, and I think we probably see a slightly younger demographic in some of these rural and remote areas, and probably have a lot of women that haven't thought along that lines, and so despite those changing recommendations, I can honestly say I've not done it on a single patient, partly because there just isn't a knowledge or awareness, and even with the discussion, it's totally off their radar. So it's something that I'd probably look at getting a little bit more written stuff so people can go away and think about it a little bit more. And being aware of the costs is good, because those costs have changed significantly in the last few years, and so I probably have been a bit out of date with what that it's much less cost now than it has been in the past. So it is more attainable for people who are on a budget.
We've got a couple of quick questions that it might be worthwhile just answering through for Alice or Melody. Is there a resource for the referral pathway, particularly for the overseas panels that are done? Like you did mention that you could sign up yourself to order them, but is there a resource you could point our audience to?
Yeah, you go, Mel.
So the panel that we use is through a company called Invitae. So that's spelled INVITAE. They are located in the US, in San Francisco. And as a provider, you can sign up online to their portal and order the test for your patients online. Then the patients will it is just a saliva sample. The patients will have to pay for the shipping, or you'll have to charge somehow for that. So you can logistically work that out, but it's just important to also have your own referral pathways if you have a high-risk couple, to know who you can contact where you can refer if you don't understand a result. They do have a representative in Australia, and the lab are quite good, so you could email them, but that, you know, your own referral pathways as well, if you're going to be ordering this yourself, that's important. And then outside of that, some of the big pathology providers also provide this screening, and it is more expensive obviously to go through them than to go directly through the American lab.
And then I presume the expanded testing also looks at beta thalassemia. Yep. And then any comment about related couples of being offered expanded testing?
So can I just say, with the THAL, although it does look at that, it is still recommended that patients have an FB and FB hemoglobin electrophoresis. So even if they're having the expanded panel, that screening for THAL is still recommended to get things that this panel might miss. And Alice, that second question, I'll let you answer that.
Yeah. So I think the question, was asking about couples who are related, and yes, it is worthwhile offering that testing. I mean, it's worthwhile offering that testing to all couples, but particularly we know individuals who are related have an increased chance of sharing, have a higher chance of carrying the same conditions compared to those who aren't related. So it's definitely worthwhile having those discussions if you know that a couple are consanguineous. Yeah.
And before pregnancy?
Yeah, so ideally, if they present before pregnancy, unfortunately, as I said before, we acknowledge that often these conversations don't occur until early pregnancy, but ideally it does sort of maximise those reproductive choices before.
One of the other questions that here I always think is a challenge in general practice for all areas. It's about helping people to understand statistics. So understanding that most of the conditions are rare, but when you group them all together, it's actually quite common to find something is a concept that I think as general practitioners we're always struggling with. And I just wondered, do you have any advice or tips for us on that? Like what's your line that you talk to people to in terms of offering these sorts of tests?
Yeah, I think the language that you used just then is really good. So sort of flagging that while individually these things might be really rare, collectively they're not so rare. And I guess just using that language to try and group them together and use that 1 in 400 statistic as opposed to looking at something like an ultra rare condition, using that in isolation. Mel, you might have some good one-liners as well to include there.
I've often heard it compared to the frequency of chromosome problems like Down syndrome. So together they're just as common as Down syndrome, is a way that I've heard people explain it.
Thank you.
There's a very thoughtful comment that someone's posted that that I don't know if it's male or female, saying that they found it of great comfort to do it as a couple. So that they wouldn't necessarily have to take on that sort of individual responsibility or feeling guilt or whatever for perhaps being a carrier. And actually is that something, Alice, that you and Mel have both experienced as well?
Yeah, so most people I've counselled have ended up doing it as a couple, and so I haven't sort of anecdotally experienced that sort of guilt. But, you know, there are lots of platforms, like I'd sort of flagged before, that only offer your risk as a couple. So instead of giving you an individual risk, they look at you and your partner, and if you pair up and carry any of the same conditions, then they would flag that with you. Otherwise, as a couple, you'd be deemed a low probability couple. And I think that might be an alternative pathway for individuals who feel like they would experience some level of guilt if they were to be found a carrier. And it's worth exploring that with them as well, and making sure they're appropriately counselled before going down the pathway of testing.
Thank you.
So I'll move on to discussing the difference between the limited and more expanded panel. So the options for testing include those panels with a more limited selection of the most frequent conditions in a Caucasian population, as we flagged before. So most often they include things like cystic fibrosis, spinal muscular atrophy, and Fragile X. These usually cost around $400, but obviously it depends on the platform. And it's also worth flagging that when there's a molecular diagnosis of cystic fibrosis in a first-degree relative, a Medicare rebate can often be obtained. Another option for testing is an expanded panel. So expanded panels are the way of the future, and more people are leaning towards these. And they test for many significant and life-limiting conditions. Additionally, as sort of Mel went through before, these panels are pan-ethnic, and so they're, cater for a more diverse population than perhaps those more limited panels do. And they can often provide valuable clinical information to patients. But it's also important to keep in mind that preferences can really vary between patients, and sometimes more isn't better for everyone. Some of the limitations are that the majority of people screened using an expanded panel will be carriers of at least one condition, which means additional resources to make sure that these patients are provided with adequate counselling so they understand what that means for them and for their partner. Additionally, it's important that patients understand the types of conditions included in these broader panels. So sometimes we can see these panels have some more, including conditions with more uncertain outcomes, and that can really complicate decision making and can cause some unnecessary anxiety for couples. And so it's just important that they're aware of the potential for some of those more incidental findings to be picked up. Next slide, please. So we'll return to Rachel, the case study that we were discussing before. So after some discussion, Rachel and her partner opt for expanded carrier screening panel, and the couples are found to be at a high probability, so 1 in 4, chance of having a child with pontocerebellar hyperplasia, which is a mouthful. So what is this condition? It causes abnormal brain development, microencephaly, intellectual disability, decreased muscle tone and vision loss. And it's a life-limiting disorder resulting in death in infancy or early childhood. So Rachel and her partner are very shocked, but they're relieved to have this result prior to the pregnancy. This has given the GP the option to discuss or refer them to someone who can discuss options, including IVF options and prenatal diagnosis. Next slide, please. So just a quick slide on our experience of offering expanded panels within our clinics. So we've tested 721 individuals with an expanded panel. 26% of these people have come back with a negative screening result, and we found that 74% of people have had an individual positive result on carrier screening. But these results were only relevant for 3% of couples. So 3% of these couples came back as carrying the same condition. And again, of note, most of these couples did not have any family history. We've also flagged that there were a couple of other clinically significant results. So some individuals were homozygous for hereditary hemochromatosis or affected with factor V latent. And as I said before, these are sort of results that that may complicate things for some people. They're, results with a less, that can have some variability, and some individuals mightn't find them as relevant for decision making in pregnancy compared to some of the more significant conditions. But things like factor V latent might be relevant for pregnant women as well. So really what we've learned from this is that screening by age, ethnicity and family history alone is not a good indicator, and that this testing really should be offered to all individuals who are planning a pregnancy.
So there's been some more questions come through, and again, I'm really interested to hear, do you offer people advice in terms of proceeding with screening from an insurance implication point of view, like for their own, if you've now been found to have factor V latent, that potentially then has an impact, doesn't it?
Yeah, so we do flag this during our consent process and make sure that individuals understand that it can have insurance implications. Mel, you might be able to comment more on sort of what those insurance implications look like at the moment.
There is, so it doesn't affect health insurance, and there is a life insurance stipulation. So up to a certain amount of life trauma income, which isn't a large amount, it's about $500,000, I believe, and differs depending on the type of insurance. You don't actually have to disclose these results to the insurer, but above that you do. We've actually made the decision, because we're actually screening couples to really check their reproductive risk of having a child with a serious genetic condition, we've taken off factor V Leiden, for example, because we don't think it's relevant in this setting. We think, you know, you as GPs can actually order that on your own if you think it's relevant for your patient. Hemochromatosis is on there, but my understanding is it shouldn't actually affect your insurance. Fragile X syndrome can, because of the chance of tremor ataxia syndrome in carriers. So we do mention that sometimes, rarely, we find something out that could have health implications for the individual, and that might actually also influence their insurance. So we ask them to consider insurance before they have their screening. But it
didn't take us long to go down the ethics rabbit hole, did it? Claire, at this point, what would you say? I mean, this would raise a lot of questions for me and how I approach this with patients.
Yeah, so like I said, like we've taken off the factor V. The majority of conditions that we screen for don't have health implications, but some of them, like Fragile X syndrome, Duchenne muscular dystrophy, women need cardiac surveillance. So there are a few that do. And we do mention it. The benefit with Fragile X is that with premutation carriers, they also have low ovarian reserve and some have premature ovarian insufficiency. So it is important that they consider their family planning, and it gives them that information to be able to do that. So there are benefits of finding this out, and thankfully it is only a few conditions that are screened that are important to still screen for because of the health of future offspring that may affect health. I think we've only had a couple of Fragile X carriers, for example. So,
Claire, were you going to make a comment?
Yeah, and I guess it goes with a lot of things that we screen for, and even taking family histories, you know, and I think increasingly insurance companies have access to pretty much our entire record, and if you don't give access, then you don't get insurance. So it's an increasing area of difficulty, and I can see it in the way that we do, for example, the non-invasive prenatal testing. We're going to find things out about an unborn child that's going to have impact their insurance down the track. So, you know, insurance companies are going to be able to link those results to future individuals. So, you know, it is a really interesting thing to keep in mind.
And I think it's a bigger question that people are looking at, and something that government needs to look at, as they've done in other countries. At the moment, the non-discrimination with income protection and that kind of thing is actually it's self-regulated by the insurance companies, and I think there are people looking at having an Australian government view policy on it with some guidelines that are enforced for insurance companies. So I think that will be good.
Yeah. I might park some of the other questions for a moment until we get through a bit more information. Are you happy with that, Peta-Ann?
Perfect. Well, I think it's the end there. Next slide, and I think I'll pass over to Mel now. We'll start us off with the case study.
All right. So this case study too is Marissa. After an uneventful preconception counselling, Marissa returned several months later, approximately 8 weeks pregnant. She asks about first trimester screening options, but wants you to know that due to COVID, money is tight, and both her and her husband have lost their jobs. What are their options? All right, so can we look at the next slide? So I've given you a brief overview of the different types of prenatal screening. Obviously, ultrasound is actually screening as well on top of these options. Combined first trimester screening and second trimester maternal serum screening both use a blood sample that looks at placental biochemistry and calculates a probability for the common trisomies. So combined first trimester looks at trisomy 21, 18, and 13, and second trimester screening looks at 21, 18, and neural tube defects. Combined first trimester screening does have a higher detection rate than second trimester screening, and the ultrasound at 12 to 13 weeks is required for this test because it not only combines that biochemistry, it also combines the nuchal translucency measurement, the presence or absence of the nasal bone, the length of the fetus, the gestational age, and the maternal age. So it factors in a number of things that go into a metric, and so it does have a higher detection rate and a false positive rate of about 5%. With the second trimester serum screen, the detection rate is lower, and it's only looking at those biochemical analytes. It's not combining those results with the ultrasound, and it is still strongly recommended that patients have that 12 to 13 week ultrasound, and I'll tell you more about that after I talk about the NIPT. So in terms of screening, NIPT is the new test on the block. It's been offered in Victoria since 2014, I believe, and probably across the country since around then. So we have had a number of years of experience with this test now. And I know where I work, we've screened, sort of 20,000 patients using NIPT. So we've got some significant experience under our belts and have learned a lot about this test. It involves a maternal blood sample taken any time after 10 weeks of gestation, and that sample examines cell-free DNA, which comes both from the placenta as well as from the mother. So even though they talk about cell-free fetal DNA, that fetal DNA is actually placental in origin rather than fetal in origin, and most of the providers can't actually tell the difference between what's maternal and what's fetal. So everything in the sample gets analyzed and put into piles. That's pile 21, pile 13, pile 18. And if the baby has Down syndrome, pile 21 should have more data or more copies in it when it's compared to pile 9. So that's kind of how the test works in a snapshot. The test screens for, it's still a screening test, so it isn't a yes/no answer. It's a low probability, high probability, or low risk, high risk. It screens for the common chromosome aneuploidy, so Down syndrome, trisomy 18, 13, and sex chromosome aneuploidy as well. Platforms these days are screening for more and more things. So some are looking at all 23 pairs of chromosomes. Some are looking at, in addition to that, gains and losses across the genome, and others are looking for microdeletions. It's important to remember that this test is very good for Down syndrome, so it has a high detection rate of greater than 99% and a very low false positive rate of 0.1%, but it doesn't perform that well for all of the chromosomes that it's looking at. That is specific to Down syndrome. It doesn't perform, I think the detection rate for trisomy 18 is around 98%, and then it decreases after that. So not as good for trisomy 13, not as good for the sex chromosomes. We don't really know with the other chromosomes, those detection rates, because those tests are new, and we know that it doesn't perform as well for the microdeletions, and that's why at the moment it's not recommended that those are screened for, because they have a very low positive predictive value. So a low chance that you'll get a high risk result and actually have an affected pregnancy.
So I've got two questions here, if I could. Yep. Just, how long do the results of each of these tests take to come back?
Yeah, so non-invasive prenatal testing, it probably depends on where you live. It takes approximately a week to come back. Sometimes a bit longer, probably, if you're in a regional or more remote area, because your sample has to get to the lab. But it's roughly about a week, so you could have results by 11 weeks, sometimes even earlier. Combined first trimester screening, we don't have a result till after we've done that ultrasound, so that 12 to 13 week ultrasound. So usually we're looking at results around that 13th week of pregnancy. And second trimester maternal serum screening isn't done till 14 weeks and beyond, ideally 15 weeks and beyond. So that will be, it's probably, again, roughly a week, depending on where you live, sometimes a few days to get those results back.
And that then leads me into Claire, just asking if she could comment on the logistics of these tests in a rural area.
Yeah, it's an interesting question. I think one of the things we've noticed over the last few years is if those of us who work in places where there isn't easy access to a nuchal translucency test, the patients are often electing to do the NIPT. It's probably important to note that though it can be done from 10 weeks in our overweight and obese patients, it is prudent to often wait another couple of weeks because they need to have a certain fraction of fetal cells, and that will often not reach that threshold until 11 or 12 weeks in an overweight or obese patient. And so I find a large percentage of my practice fall into that category. So it is often around that 12-week that we do that. And for accessing, in my area, it's an 800-kilometre round trip to get a nuchal scan, and there's similarities in many other places. We're lucky enough that we have antenatal ultrasound locally, but don't have nuchal. So we can still do a 12-week ultrasound, though it's not a nuchal translucency test. A lot of remote places will have some sort of access, but in many places, just to even have the dating scan and to have a standard ultrasound is a long trip. That's where I think the NIPT has provided some local advantage for remote women, because it's a blood sample that can be sent from anywhere. So, it's certainly a big advance.
Thank you. Yeah.
So I guess, yep, go ahead.
You're up.
No, we've got lots of questions. So Beck, I don't know, do you want to get through some of them now, or do you want to keep going with? Yeah.
I'd be interested to know if there's Medicare rebate or bulk billing options for any IVF or pre-implantation testing if people have returned high-risk tests. This is sort of going back to the previous.
Yeah. So Mackenzie's mission, so there have been lots of people trying to lobby the government for this for a long time. As part of the Mackenzie's mission research project that they're funding, they are rolling that in. So we're hoping that there may be some Medicare funding for the pre-implantation testing. At the moment,
not.
Yeah.
And can any of that testing be done in second trimester? Or, like I did notice, you said the turnaround time was up to sort of 4 weeks, so that would be quite challenging, I imagine.
Yeah, so you mean the carrier screening testing?
Mm-hmm.
I guess the disadvantage of, you can do it at any time, but what are you going to do if the couple are high risk and they're in the second trimester or third trimester of pregnancy by the time you get a result? Their options are then very limited. So you can test the pregnancy, but you may or may not be able to access the termination of pregnancy and that kind of thing. So those are important considerations when offering it.
Yeah. How are twin pregnancies handled in terms of the the prenatal screening that you're talking about here?
Yeah, so if you've got an ongoing pregnancy with 2 twins, any of these screening tests are fine. If you've got a demised twin, NIPT is not a good test. So if you've got one live fetus and one fetus that is no longer alive, or an empty gestational sac even, NIPT is not a good test, because we know that there's still DNA from that other twin, and we're more likely to get a false positive or a false negative in that case with NIPT, because there's data that shows that that twin that's deceased or that empty sac is actually producing more DNA than the ongoing pregnancy. So it could mask a pregnancy with something. So it is important if there's 2 fetuses and they've both got heartbeats, NIPT is fine. But if there's an empty sac or a demised or vanishing twin, as they call it, combined screening is the better test in that scenario.
And then there's a very specific question here. So if a patient has had a Noonan baby in a previous pregnancy, would you recommend the patient to have expanded testing? They've never had any carrier screening.
So I guess carrier screening should be offered for everybody. So from that point of view, it should be offered to this couple. In terms of the recurrence risk for Noonan syndrome, that would be something that we could test with prenatal diagnosis or pre-implantation testing. And there are also things we look for in ultrasound. Babies with Noonan syndrome tend to have very big nuchal translucencies. They can often have heart problems. So it's probably important that in a subsequent pregnancy, they're referred to a tertiary centre if you have one near you that's not, 8 hours away or 800 kilometres away. If you have access, obviously that's ideal that they're referred to a tertiary centre where we can perform ultrasound. That's going to be their best bet.
Yeah. And then how do you deal with variants of uncertain significance? And I suppose this happens in all tests, really, doesn't it?
Yep. So we do get uncertain variants quite a lot with prenatal diagnosis and microarray analysis. Uncertainty in prenatal screening and testing is something that we've had to deal with for a long time. We often get grey results, and I'm sure in your practice as GPs there's uncertainty as well. Often with the uncertain variants, we have to test both parents, and if it's come from one of them, we tend to be more reassuring that they're fine, and so hopefully it shouldn't actually mean anything for the fetus. But that's something that should be probably referred to a geneticist or a genetic counsellor to manage. Yeah. If possible.
We might keep going here just for a few more slides. I'm aware, can you believe it's 7:45, so we've only got 15 minutes left.
Okay, well, I'll just quickly say that if accessible with NIPT, that 12 to 13 week ultrasound is still strongly recommended. So in all three instances, and that's because even if you're not measuring a nuchal, it's still important to look at anatomy. There are things that we can detect at that stage that we would rather detect rather than finding them at 20 weeks, for example. And if your couple, as in this case with Rachel, financially are struggling, you're better off having the combined screen and a 12 to 13 week ultrasound, because you'll miss less than if you just have NIPT and no scan. But that obviously is with the caveat that if the scan is accessible. So for those of you where the nuchal scan or an anatomy scan isn't accessible, NIPT might be your only option. Should we go on to the next slide? Because we've got a few more to get through. All right. So Marissa, which is in case 2, sorry, I think I said Rachel, but Marissa elects to have a nuchal translucency test at the nearest facility, which is 400 kilometers away, and she returns a result of 1 in 200 for trisomy 21. So this would be an increased risk result on the combined screen. What does this mean for Marissa's pregnancy? I'm going to go through this relatively quickly. Obviously, that means 199 out of 200 women with this result will not have a baby with Down syndrome, and 1 out of 200 will. So there's much more chances with this result that the baby doesn't have Down syndrome, but it's important to discuss this result with Marissa and work out if this is information she wants to know and what she would do with that result. In terms of her options, keeping in mind her location and budget. So I'm not sure, you know, she was able to go 400k away for a nuchal. I'm not sure how far away a CVS or amnio would be in Marissa's case. Very far. Very far. So a good option with this particular risk would be NIPT, which we know has a detection rate of greater than 99% for Down syndrome. So it's a very good test for the condition she has screened high risk for, as long as she is aware that that test isn't going to give her a yes or no. It's going to give her high probability, low probability for that condition. So Claire, Marissa's your patient.
And I've had very similar, and that's ended up what we've had to do. So we've returned, you know, a higher risk result with a nuchal, and on consultation with fetal medicine specialists that recommended an NIPT in that situation, and the result was low risk. So it was thought that, you know, it was that was enough to reassure the patient. And obviously there is the option, if they preferred to have definitive testing, to travel. For much of Queensland, they would either have to travel for a lot of the west into Brisbane, but most of the regional centres in their public hospital system do offer amniocentesis. However, in this particular case, it was a patient in the public system, and they said they wouldn't do an amniocentesis unless they had an NIPT, which the patient had to pay for themselves. So it is an interesting ethical dilemma as well, where someone's in the public system, but they're being forced to, you know, pay for a test before they can get definitive diagnosis.
And it probably at this point, doesn't it, Claire, it becomes that issue where you say to your patient, look, the decision path here now really depends a lot on whether or not termination is something you would want to consider highly, or whether you're going to proceed no matter what, and in those cases an NIPT would probably be a reasonable decision, wouldn't it, if the pregnancy will proceed no matter what? Would you agree with that,
Yeah,
Claire?
absolutely.
Yeah.
And some elect not to have any further testing because it isn't going to alter significantly. And I know that's a point of contention that we don't do this testing just to know whether a termination is an option or not, and it does guide some options down the track. But that is often the decision point that people arrive to, and some do pay into the private system at this point to have the tests that they would like in a timely fashion. And so I think comparing the costs of having a definitive answer and the cost of raising a child lifelong and not having the options, when you look at it like that, then a lot of people will pay into the private system to have further testing and stuff done. And the majority of my patients actually go and see fetal medicine privately in Brisbane if they need amniocentesis or CVS. And I think also there is a bit of evidence that the success, the risk with those particular invasive tests reduces with experience, and so that's where people do elect to go and see an experienced operator in that field.
Claire, there's someone asking you a very specific question, which I think I know the answer to, but I'm just going to see what you say is, will Queensland Health pay for travel costs?
Yes, they will. So PTS covers termination now as well. So it's something interesting that's only just changed since the legislation changed last year. So they will pay for travel costs for all of this testing, even the stuff that's not offered in the public system.
It is a shame that there is no Medicare subsidy, or given that for some remote patients, this NIPT is probably their best or maybe only choice. It is a shame that isn't subsidised, because it is expensive. $400 is a lot of money.
Yes, exactly. The NIPT isn't, but most public hospitals will. Most regional centres will offer Nagle, and so the stupidity is that we'll pay a lot more money to pay patient travel and to pay the cost of Nagle test, send someone 700-kilometre plane ride to have that done, whereas it could have all been just subsidise one NIPT test and do a local ultrasound. So it's not always common sense in these policy matters.
That's right. Now we've got 8 minutes to go. We've still got another case to get through very briefly, and then to talk about Cate's decision-making tool. So Melody, we might keep going if that's okay.
Next slide, please. All right, so this final case study is Emily. So this is also a real case. We've used real cases throughout this. It was Emily's second pregnancy. She had a well 2-year-old at home. She was 31, and she wanted an NIPT just for maternal preference. So she wanted it as a better screening test, no other reason. She had a pre-scan with us, which we do offer and bulk bill. Mainly because we're looking for contraindications for an IPT, like a demised twin or a miscarriage. So before someone pays all that money, we want to make sure that they've got a viable pregnancy. She then returned the following week, because we won't do the blood collection before 10 weeks. It's not a validated test. It increases the chance we won't have enough DNA and that the test will fail. So she returned the following week for a blood draw at 10.5, and something should animate here. This was her result, hopefully. Good. So this was Emily's result. It came back as a high risk for trisomy 13. You can see the fetal DNA percentage is 5.6. So this particular platform needs a fetal DNA percentage of 4 or more. So that's within that. Usually at around the 10-week mark, there should be 10%. So it is slightly low, but we don't worry about that. What you can see as well is they've given you a probability, and this is what I want you to focus on. It's given you a probability of greater than 99%, and that makes you think it's very likely that this baby has trisomy 13, but this probability is not actually the positive predictive value or the true chance that the fetus is affected, and I'm going to go through that a bit more with you. And so I feel like these reports that report like this are deceptive because of that. This is the lab's confidence that they're seeing trisomy 13 in the sample, but that doesn't actually mean it's come from the fetus. So next slide. I got this result and I thought, could this be the reason that the fetus was behind dates a week? I actually informed Emily's GP first, then I rang her and informed her of the results, and she was understandably shocked and upset. I discussed the main clinical features of trisomy 13 and discussed that this result was only a high probability. It didn't mean that the fetus was actually affected, but that invasive genetic testing would be recommended if she wished to confirm these results. And then what we do is we book them in for an ultrasound scan. So we had a scan performed the following day, and there were no abnormalities detected on that scan. So at that point, I calculated and discussed the positive predictive value for trisomy 13, because in experienced hands, we should, with the majority of fetuses with trisomy 13, we should be able to see something on the ultrasound. So given that there was nothing on the scan, we were thinking, could this be confined placental mosaicism? So where the placenta has trisomy 13, but the fetus doesn't, and remembering that NIPT is only looking at cells or DNA from the placenta, not actually from the fetus. So because the fetus looked completely fine on ultrasound and this possibility of CPM, we counselled her that it would be a better test for her to have an amnio over a CVS that is more representative of the fetus. Those are fetal cells, and we're not then testing the same cell line again with a CVS, which could increase the chance of us getting a high risk result with an unaffected fetus or a mosaic result and having to do an amnio anyway. Next slide. So this is the positive predictive value calculator. I've given you a reference there. If you Google mom baby PPV calculator or Google University of North Carolina PPV calculator, this will come up. I plugged in Emily's age, which was 31 at the time she had the test, the gestational age in weeks when we sampled to the blood, and the test we were using at the time was Harmony. We now use Illumina, which is you select verify for. And when you look at that, you can see the PPV at her age at that gestation for trisomy 13 is only 20%. So even though that report said there is a 99% probability, the chance that that fetus is truly affected is only 20%, and there's an 80% chance of an unaffected fetus. So we've actually found calculating these results, I don't calculate them for trisomy 21 because you're very unlikely to get a false positive, but I do calculate them for 18 and 13, where we are more likely to get a false positive for those chromosomes, and that really helps the decision making and the counselling, and also provides a little bit of reassurance, which is what I think people need when it often takes time for them to be able to access ultrasound or further testing.
Gosh, thanks, Menezes. That's a fabulous resource. I'm going to hand over to Cate now just to take us through the decision-making tool for the last few minutes. So if we could go to the next slide, please. Oh, we're going to skip over this. Sorry, Melody, because yeah. Next slide, please. That's it. Cate, off you go.
Great. So to let you know about a resource that's freely available and has been for quite some time, it was taken up, the results of my PhD actually over 10 years ago now, was taken up by RANZCOG in its paper form. Since then, with all these new tests, it's been updated and is available on the MCRI website. If you just put in MCRI for Murdoch Children's Research Institute and prenatal testing, you'll get access to this decision support. Next slide, thanks. We are converting it to a app, and actually if you could just click again so we get that information up, terrific. So we are putting it into app form to make it more accessible. Essentially what it is, it's decision aids meant to be adjuvant to clinical care. It's used when there are a variety of different equitable sort of options or equivalent options, but it provides value-based support as well as information and the extent of information that the woman wants herself, and that, as we know, that can be quite variable. It's known to, it was tested in a cluster RCT and was showed to increase women's informed decision making, that is, decisions that are based on the right information consistent with their values, didn't change decisional conflict, didn't change anxiety, but did dramatically increase women's understanding of numeric risk. And that obviously, as we've said a number of times this evening, that's something that women do grapple with. So presented in a variety of different engaging ways, and certainly happy for you to contact me if you're wanting access to it.
Thanks, Cate. So just to clarify, is this something that you would recommend that the woman or the couple do on their own prior or after chatting with the GP, or to do it with the GP?
I think it's best for the women and the woman and her partner to do it, even if pre-pregnancy ideally, but that's oftentimes not possible, but certainly in early pregnancy, and then to bring it to the consultation for exploration of, it gives the results page with this algorithm that's been developed and tested, gives the sort of weighing of what tests they're leading towards, which can be a useful, and with time poor consultations, it's a useful sort of head start to enter that the consultation with them having the right information in a form they can understand, and having considered and reflected on their values and what amount of information will be important to them with regard to the testing.
Thank you so much. I can't believe once again we've run out of time. So just before we put the QR code up, I'm going to go around the panel and just ask for any last comments. Alice, maybe we start with you. Your top tip or your big...
No really other comments, but thank you so much for having me, and yeah, it was a great thing to be part of.
Mel.
Yeah, thank you for having me as well. That was very interesting, and I really enjoyed the discussion and the comments, and I'm happy to answer more questions if needed, or can provide my email address.
Thank you. What would you like us to take away?
I think that PPV is a big one, and I find that it really helps patients in their decision making, and understanding that NIPT is still a screening test. We still get false positives and false negatives.
Thank you. Claire.
I think my take home is that it doesn't really matter where you are. I think women who are approaching this stage of their life really expect the best kind of advice. And so whether we're remote, rural or urban, as GPs, it's our responsibility to be across this and understand what our options are for our patients.
Thanks very much. And a big thank you to our panellists for fascinating and very informative evening. Thank you ever so much. Good night, everyone.